Hi, I'm Dr. Hannah de Guzman, and I'll be talking about interpretation of visual field test results, specifically standard automated perimetry. I'm a glaucoma specialist and I have no relevant financial disclosures. This lecture is about the process of interpretation. There are not a lot of examples of visual field results because that's what atlases are for. The process actually starts in the clinic when we first examine and meet the patient. There are certain things that we need to find out that will help guide us when we request the test and when we interpret the test. The type of patient may dictate the choice of program that we request for, and so will the visual acuity. It will dictate what type of stimulus size we use and what type of program. We should make sure the patient has the correct refraction for the test. Most machines test the patients at 30 centimeters away, but some models don't need any ads for reading. The probable diagnosis will affect our choice of test or fixation target. So those with macular conditions, use a large fixation target, or if you're screening for maculopathy, just do the central 10 degrees, no need to do the entire 30 or 24 degree test. Neurologic conditions can usually be tested with glaucoma programs because the neuro programs of the machines that we use tend to take very long, and that's really torture for some patients. Patients with ptosis, if you want to avoid lid artifacts, then you can have their lids taped during the test, unless you're actually documenting the amount of effect that the ptosis has on the visual field. Then you don't tape the lids. The disc appearance will also dictate our choice of test and where we will look on the visual field once we get the results. Before we start to interpret the test, we should recall the relevant anatomy of the visual pathway. So either the RNFL bundle or the visual pathway. And we have to keep in mind the patient's clinical picture. And we lay the fields left on the left, right on the right, so it's easier to understand and to highlight neurologic defects. Step 3 is the general data. This is where you can find it. And this is what it looks like for the Humphrey and the Octopus. The name should be the same for every test for future statistical analysis by the machine. If the name is different, if the patient's name is spelled differently, or the first test had the full name, second test didn't have the middle name, then the machine will think those are two different patients and the results cannot be compared. The date of birth must be correct because the patient is compared with a normative database of the same age. The pupil size should not be too big or too small. The refraction should be the correct one used, or else you could get artifacts because of that. And make sure that the test type, stimulus strategy, and fixation target are what you wanted. So this is where you can find the test used. There are different programs available in our different perimetry machines, and when we choose a program, the area to be tested, the distribution of the stimuli, and the size of the stimulus are already set for us. So it's usually 30 degrees, 10 degrees, or 24 degrees that we test. And these are the distribution matrices of the two commonly used machines. The size of the stimulus is usually Goldman size 3, and for low vision tests we use the Goldman size 5. These are the sizes of the two different Goldman stimuli in relation to the blind spot. These are the names of the most commonly used programs of the Humphrey and Octopus machines for different conditions. The strategy is the algorithm that the machine uses for presenting the stimuli to the patient. In general, there are three types: the full threshold, what I like to call the balanced, and the fast screening. The full threshold test maps the threshold at every point on the matrix. It's the most sensitive, but it's also prone to artifacts due to fatigue and inattention because of the long test time. 15 to 18 minutes per eye is very long. I recommend that every ophthalmologist should do a visual field test so that we know what it feels like and we know what we are putting our patients through every time we send them for a visual field test. This is an example of how a full threshold algorithm will determine the patient's threshold. So it starts with a very dim stimulus, and if the patient did not see it, then it gives a 4 decibel brighter stimulus. If the patient still did not see it, it goes brighter again by another 4 decibels, but this time the patient saw it, so now the machine goes dimmer again by 2 decibels this time. If the patient did not see it, the machine now goes back to brighter, but this time by only 1 decibel. So this is called bracketing the threshold, and by doing these steps all at one point, the machine is able to determine the patient's threshold at that point. Take note that these stimuli are not presented sequentially all at the same point. So the machine will test one point here, another point here, another point here, then another point here, and then come back here. So the patient does not know where to expect the stimulus. Now what I call balance tests are shorter than the full threshold, but still have very good sensitivity. However, they may miss shallow defects. So special algorithms are used, and it starts with determining the full threshold, but only at a few points. And then the machine tailors the subsequent stimuli based on the patient's responses to the full threshold determination and the earlier responses. So it's a lot shorter, only 4 to 7 minutes per eye. The fast screening tests are very short in duration, but they're the least sensitive. So they're only recommended for patients with poor attention span or who won't be able to stay in the testing position for long enough. So it's about 2 to 4 minutes per eye. This is a table of the two commonly used perimetry machines and the different types of algorithms: the full, the balance, and the fast. So a summary of the programs and the strategies that are available on the Humphrey and the Octopus. These are some common mistakes regarding the test used. First would be the inappropriate test was used, or not taking into consideration the type of test while interpreting the results. So make sure that you ask for the right test to begin with and check what program was actually used. And look at the general data first, don't jump straight to the maps, and keep the test type in mind while interpreting the results. What I wish was included in the general data is the patient experience. I wish there was a spot there which indicates how many perimetry tests the patient has done already, because people who are new to perimetry can have very unpredictable results. So what you do is just ask the patient how many times they've done a visual field. Before the visual field, especially before the first time, it would help if you were to advise them on what to expect. This will improve their performance. And The only way you can advise someone what to expect is if you have experienced it yourself, as I said earlier. After the visual field test, ask for feedback, ask how the test went, and interpret the results with their responses in mind. For example, if the patient says, "Yeah, during that last perimetry, I was getting a little sleepy, my eyes were drying up." So you now know you will understand why maybe there's more artifacts this time, or why the results are not so reliable this time. Here's an example of how patient experience can affect the test. This is the first field with good reliability parameters. The false negatives could just be because there are scotomas there. So it looks like a double arcuate with central and temporal islands remaining. But on repeat testing, they're all gone because it's just learning effect. The next step are the reliability indices, and these are where you can find them. On the Humphrey, we have the fixation losses, false positive errors, false negative errors, test duration, and the gaze tracker in the newer machines. Whereas in the Octopus, we have test duration, catch trials, and reliability factor. So we'll talk about fixation losses and false positives or catch trials and test duration first. Test duration, if it's too long, it's less reliable. Like I said earlier, these are the number of minutes for each eye for the different types of programs or algorithms. False positive errors or positive catch trials occur when the patient responds when there was no stimulus. The machine makes a sound every time a light is flashed, and there will be times when the machine will make the same sound but not flash a light. This is to catch the patients who are trigger happy, and sometimes they're just anxious to get a good result. Ideally, you want this number to be 0, and on the Humphrey it'll be flagged as XX if it's 33% or more. False negative errors or negative catch trials are when the patient fails to respond to a brighter stimulus when earlier they had responded to a dimmer stimulus. So this could be that the patient is no longer paying attention or fatigued later on, because this is later on in the test. Or it could be the edge of a scotoma, in which case your high false negative errors or high negative catch trials would not be an indicator of poor reliability, or the test would still be reliable. So the Humphrey will also flag it as XX if it's at 33% or more. Fixation losses are only mentioned on the Humphrey because the Octopus automatically discounts all results from the times when the patient was not fixating. So fixation losses are caught when the patient responds to a stimulus presented at the blind spot where they're not supposed to see anything. So the patient is either not fixating properly, or the patient is trigger happy and responding just to the sound. So the maximum acceptable is 20%, although ideally you want this to be 0. The Humphrey has what they call the gaze tracker. So if the patient's pupil moves, they indicate an upstroke on the gaze tracker, and if the patient's pupil was blocked, such as by a blink or a droopy lid, they indicate this with a downstroke. So what you want is a flat gaze tracker with minimal up and down strokes. The Octopus, on the other hand, has the reliability factor, which is essentially the positive and negative catch trials recorded as a percentage. You want this number to be 15% or lower, but you can accept a higher number if the negative catch trials are high due to the presence of a real defect. So remember that high false positives can be acceptable if there's a significant defect, because the variability comes from the edge of the scotoma. Perfect reliability indices can still be unreliable, especially in first-timers and the fast screening tests, which are less sensitive. So you have to take all the other elements of the visual field as a whole and not just rely purely on the reliability indices as your indicator of reliability. So never make an important clinical decision based on an unreliable test. And there are patients out there who will never ever be able to produce a reliable test. So these patients, you can just stop requesting perimetry and just use some other means to monitor them. The next step is the grayscale, and this is where you can find it. The grayscale just deserves a quick glance. Don't use it for interpretation. It's most useful for explaining the results to the patients. Now this is really the meat of the results, the probability plots. This is where you can find them. These are the probability plots of the Humphrey and Octopus. They have different names, but they're just the same. The total deviation of the Humphrey is just the same as the comparisons and probability plots of the Octopus, and the pattern deviation of the Humphrey is just the same as the corrected comparisons and corrected probability of the Octopus. So total deviation, or comparisons and probability, are threshold data compared point by point with the age-matched database. So it indicates the overall height of the hill of vision, and if there is generalized depression, that's where it'll show up. And it may indicate a focal defect, but you can't confirm it just based on the total deviation. The pattern deviation, or the corrected comparisons and corrected probability, are the total deviation corrected for generalized depression. It indicates the smoothness of the hill of vision, so this is where any focal defects will become evident. So it confirms the presence of a scotoma that might or might not have been obvious on the total deviation plot. The probability plots have probability, or p-values, which indicate the probability that that is a normal result. So the higher the number after the less than sign, the higher the likelihood that that is a normal result. So we read the probability plots from left to right as if we're reading a book or a sentence. So we can make a preliminary conclusion with the total deviation plot, but we can only confirm it after seeing the pattern deviation plot. So the things that we can conclude after looking at the probability plots are that it's normal, or that there's generalized depression, or a focal defect, or both generalized depression and a focal defect. So here are some examples. On the left is a normal probability plot, normal total deviation plot, which will also have a normal pattern deviation plot. On the right is a generalized depression, what looks like generalized depression on the total deviation plot. And so you can see how clean it is on the pattern deviation plot, so it really is just generalized depression. So it's an overall decrease in the height of the hill of vision. Here's another example of generalized depression, but there's also a lens rim artifact. On the left is what looks like a scotoma on the total deviation plot, a focal defect, but we can only confirm it when we see the pattern deviation plot. On the right, we have what looks like is just generalized depression, but when we look at the pattern deviation plot, we realize that aside from the generalized depression, there is also a focal defect. So an overall decrease in the height of the hill of vision with the focal pit or pothole. The next thing to look at are the global indices, and this is where we can find them. So these are what the global indices look like for the Humphrey and the Octopus. The longer tests will have more indices, and the shorter tests will have fewer indices. You can think of the global indices as being sort of summaries of the total deviation and pattern deviation plots. Octopus gives the mean sensitivity, which is just the average sensitivity values of all points. Humphrey and Octopus both have something called MD, which is mean deviation in Humphrey and mean defect in Octopus. And what they are is the average difference of each point from the age-matched normal. The pattern standard deviation, or the loss variance for Octopus, are an indicator of the variability of the points, or the degree of difference from each point from another. And short-term fluctuation is the same for both tests. It is the standard deviation of the points that were tested twice. So on the shorter tests that only have one phase, there will be no value for short-term fluctuation. Corrected pattern standard deviation, or corrected loss variance, are the PSD or LV corrected for the short-term fluctuation. What do the global indices indicate? The mean sensitivity is the average sensitivity. MD indicates generalized depression and/or a focal defect. So think of it as the total deviation plot distilled into a single value. Values of more than plus or minus 2 are abnormal, and the further away it is from 0, the more abnormal it is. PSD or LV indicate unevenness of the hill of vision, or the presence of a focal defect. So you can think of it as the pattern deviation plot distilled into a single value. And a number above 6 is abnormal, and the higher the number, the worse it is. SF indicates intratest variability. That variability can be either due to the patient reliability or due to disease. So you can think of it as another reliability index, and a value over 2 is abnormal. The CPSD or CLV are better than the PSD or LV if the short-term fluctuation is due to an unreliable test. But if the short-term fluctuation is due to disease, then you're better off relying on the PSD or LV. So think of it as an alternate for the PSD or LV. And a value over 4 is abnormal, and the further away it is from 0, the worse it is. So the simple way to think about the global indices is here in this column. So this is what you need to remember. Next are the features that are unique to each machine. This is where you can find them. So for the Humphrey, we have the GHD and the VFI. VFI is Visual Field Index. It gives a percentage of the current test as a percent of an age-adjusted normal visual field. So the closer it is to 100, the better. The glaucoma hemifield test, it compares matching zones in the superior and inferior hemifields to detect asymmetry across the horizontal midline. So the Humphrey GHD has 5 possible results: within normal limits, borderline, outside normal limits, abnormally high sensitivity, general reduction of sensitivity. These are the zones that the GHD compares. Zone 1 superiorly is compared with Zone 1 inferiorly. Zone 2 superiorly is compared with Zone 2 inferiorly, and so on. So the simple way to think about the GHD results are to group them into 3. So there's normal, and then there are the results which comment on the symmetry, which is either borderline or outside normal limits, and then there are the results which comment on the sensitivity, either abnormally high or generalized reduction or generalized depression. The unique feature of the octopus is the cumulative defect curve, also known as the Bepier curve. It sorts all of the decibel values from highest to lowest regardless of their position in the field. So this point may not necessarily be adjacent to this point, but they are adjacent in terms of height or how sensitive they are. The shape of the curve can indicate either generalized and/or focal defects. So this is a normal curve. It's within the blue lines which indicate the upper and lower limits of normal. This is generalized depression. All the points are below the lower limit of normal, but all more or less equally below. This is generalized depression with a focal defect, and this is no generalized depression with a large focal defect. Another thing we can look at are the actual values, and this is where you can find them. In certain situations, we may need to look at the actual values. For example, when comparing across multiple fields, especially if your machine does not have the advanced progression analysis software, or in severely depressed fields like this one shown here. Also, it'll help you detect trigger-happy patients. When you see superhuman values like more than 36 in a young patient or more than 32 in an old patient, then you know that the patient is trigger-happy. The last step is to assess the defects that we see on the visual field. We have to tell or determine, is it a real defect or just an artifact? And if it's a real defect, does it match the structure and our diagnosis? Artifacts are extremely common in perimetry, and very often we can mistake them for real defects. You can have an artifact in the presence of excellent reliability indices. The bizarre looking or the classic artifacts are easy to identify as artifacts and dismiss them, but sometimes you have artifacts that kind of look like glaucoma, so these are the ones that can be very misleading. So we need to check reproducibility, consider the patient's experience of doing visual fields, and always correlate with the structural findings. These are common causes of artifacts. So these are examples of obvious artifacts. We have the learning effect cloverleaf and the very classic lens rim artifact. Take note, however, that learning effects do not always look like this. So here's an example of a glaucoma-like artifact. So this looks like a possible incomplete superior arcuate scotoma, the very good reliability. But when we look at the patient's disc, if we look in the corresponding area, the RNFL looks very healthy and the neuroretinal rim is still quite thick. So what is it? When we do a repeat test, it's not reproducible. There are 4 patterns of visual field loss that are specific to glaucoma that follow the nerve fiber bundle pattern and extend from the blind spot. And then 3 of these, except for the temporal wedge, also respect the horizontal midline. Generalized depression and blind spot enlargement can also be seen in glaucoma, but they are not specific for glaucoma and can be seen in other eye conditions. We have to keep the RNFL anatomic pattern in mind whenever we are interpreting visual field results. This is a schematic diagram of the RNFL, and this is the area responsible for the central 30 degrees of the visual field, and this is the area responsible for the central 15 degrees of visual field. Conveniently for us, the octopus also has its circles at the same points. Unfortunately, the Humphrey does not. So this is 30 degrees, and this is 15 degrees. Here is an example of a nasal step defect, and the area of the retina that would be affected would be here. But since it's often hard to see RNFL defects, we look for the defects on the optic nerve. Now, how would we know where to look on the optic nerve for the defect? What we do is we trace the RNFL bundle back towards the optic nerve from the defect. So, in this case, we would look for the optic nerve, the neuroretinal rim defect on the inferior temporal part of the rim. On the right side, we have an example of an arcuate scotoma. And this is the part of the retina that would be affected. On the left, we have an example of a paracentral scotoma. It emanates or extends from the blind spot in an arcuate pattern within the central 10 degrees of field. And the area of the retina that would be affected would be here. On the right, we have a temporal wedge defect. Unfortunately, with a lid artifact, it's very hard to find a pure temporal wedge defect because these are very rare. So this is the temporal wedge defect, and that is the retina that would be affected. It gets confusing when there are multiple defects in a single visual field and the defects are all differing degrees or sizes, or they're not complete. Here is the partial inferior arcuate defect with the corresponding area of the retina affected, the inferior paracentral, and the partial superior arcuate. On the other side, there's a superior nasal step defect, a partial superior paracentral, partial inferior arcuate defect. The way I've been showing it to you so far is to match the visual field with the corresponding appearance as if you were looking at a disc photo. This is the actual disc photo that goes with this visual field. See the RNFL wedge defect that corresponds with our paracentral defect. The area encompassed by the disc photo is shown here on the schematic diagram. The problem occurs when we are actually looking at the slit lamp. We need to rotate this image 180 degrees in our mind so that it will be the same orientation as this disc photo and schematic diagram, so that we can start to compare it or interpret it with the visual field. So we need to practice rotating what we see at the slit lamp in our minds 180 degrees. And the only thing we can do to get good at that is to practice. Other common pitfalls when interpreting perimetry results are interpreting the visual field alone without correlating it with the structural tests, not getting a proper baseline, not checking for reproducibility of the results, and improper frequency of testing. So we must never try to analyze the field independent of the structural tests. The visual field should always match the appearance of the disc and the RNFL. If it doesn't, then it might not be glaucoma. So here's an example of what looks like a superior sidal scotoma that's reproducible. It's not an artifact, it's reproducible, it's significant, it follows the RNFL pattern. So are we going to start glaucoma treatment? Well, it turns out that the patient has an old commotio retinae, which just happens to affect an area of retina that kind of follows the RNFL bundle pattern, which is why we have this pattern of visual field loss. Another problem is not getting a proper baseline, which Sometimes this happens because we are trying to be economical, especially in settings where patients have to shell out for their own tests. The number of tests we need to get a reliable baseline can vary from 1 to infinity. Infinity are those patients who will never ever be able to produce a reliable field. This is often a problem for newly diagnosed early to moderate cases where the defects are not so obvious. So all we can do is to reassure the patients and explain to them that we really need to get more tests at the beginning because of the subjective nature of visual field tests. Another common mistake is to make decisions based on the change in a single field. Don't hesitate to get a repeat test or even a second or a third test before making a major decision such as surgery. Sometimes progression can just be long-term fluctuation. So make sure you get a repeat test, that the change is a reproducible one, and you should also find a corresponding structural change, unless it's very advanced glaucoma, in which case you might not see a structural change to correspond with your functional change. Here's an example of long-term fluctuation. You can see the MD going up and down from 14.9 to 16.5, 17, and back down to 15.4. You can also see the defects getting larger than smaller than larger than smaller. Now if you were to see this visual field and then on the next visual field you see this worsening, you might think that the patient is progressing, and you might want to change the medication, add a medication, or even recommend surgery. But if you need to check for reproducibility and do it again, and then that's when you'll see that it's just long-term fluctuation. Another common mistake is improper frequency of testing. So we might be doing too frequently or too infrequently. There are a lot of factors that come into play that cause this problem. But one thing we can do is to reject the temptation to order an entire package, just fields plus imaging plus photo, if we only need a field. So be selective about what you request. So this is a general guide to the frequency of testing for a glaucoma suspect who's low risk. We should emphasize monitoring the structure, and you're entirely justified if you decide not to do a visual field test, because it's just going to be normal, and if it's not normal, it's just going to confuse you. Glaucoma suspects which are higher risk still emphasize monitoring of the structure, but here you might want to do a visual field already every 1 to 2 years. Early or stable glaucoma can be tested just once or twice a year, and more frequently if it's advanced or uncontrolled. These recommendations are after you've gotten your baseline tests. So this is for regular monitoring. So you need to get an initial baseline of 2 or 3 tests in the first year so that you have a reliable baseline for the long term. So thank you for listening, and I hope I've made perimetry interpretation easier for you.